Hello, Prof.
We're starting in a moment. Just let's give the
I need to create if I need to share my camera. I'll have to close the Zoom and start again.
No, don't worry.
We can proceed without the camera.
Yeah, okay. Don't worry. You can proceed without the camera. Okay, let's just see our attendees. And we'll just wait a minute before we start. Hi, everyone. Welcome. My name is Shabir Musa, the Executive Coordinator of the African Forum for Primary Health Care. We have our usual continuing professional development for African primary health care practitioners. Today, we're really fortunate in having Dr. Anne Alagadede, who is a family medicine registrar from the Department of Family Medicine in Primary Health Care in Johannesburg Health District. She's also at the University of Witwatersrand. And what really I think is special and how people find useful is the fact that young registrars who are preparing for exams tend to be on the edge of things and share and prepare and share very, very useful insights with a strong orientation to primary care. So thank you, Anne, for being willing to do this. You can share your screen, and begin to unmute yourself. Over to you, Anne.
Okay.
Anne, if you could just put it on share slide or slide view.
Okay.
Right. Yep, there we go.
Yes. All right.
Thank you, Anne.
Thank you, Prof. Today we're talking about hypertensive disorders in pregnancy for the primary care physician. I'm Anne Alagadede. So all references to this presentation can be found in these 3 articles. The national guidelines for 2018-2019 published in the South African Medical Journal, an approach to hypertension physician journal, and also the Journal of Hypertension by Brown et al. In 2018, where they look at the International Society for the Study of Hypertensive Disorders in Pregnancy classification. All right, so moving on, this is the article published in the South African Family Practice Journal, and the algorithms that you'll be seeing are coming from this article. All right, so when we look at the Savings Mothers Report in 2017, it highlights over the last decade the most common causes of potentially reversible causes of maternal mortality. So this graph you are looking at here looks at non-pregnancy related infections, obstetric hemorrhage, hypertension, and pre-existing medical and surgical conditions. So as you can see from the graph, hypertension is the gray bar here. And over the last decade, the trend in the hypertensive disorders in pregnancy causing maternal mortality has not reduced. So here we are looking at it over here. And as we go on to 2014, 2016, it actually increased and stayed at the same level in 2017. As compared to the other factors that appeared to be decreasing, hypertension kept on being high in pregnancy and causing maternal mortality. Moving on, so using that information, they looked at why hypertensive disorders in pregnancy were still quite high over that period. And they found out this, that in the CHC, marked by the blue bar here, the district hospital is a gold bar, regional hospital green, and tertiary hospital orange. You notice that in the CHC and the district hospital, so the CHC is here, the district hospital is there, the causes of death due to hypertensive disorders in pregnancy were due to wrongful diagnosis and poor early assessment of these women, as compared to the regional hospital, which is the green bar here, which shows here that not following protocol was actually the cause of deaths and hypertensive disorders of pregnancy at the regional hospital. So using this information, our presentation today is going to focus mainly on correctly diagnosing hypertension in pregnancy and also the early management and transfer of these mothers. The hypertension in pregnancy is defined as a clinical systolic blood pressure above or equal 140/90 milliliters of mercury, or a diastolic blood pressure above or equal 90 milliliters of mercury, based on the average of at least 2 measurements taken at least 15 minutes apart using the same arm. I'm sure other guidelines that some of our colleagues have seen or maybe using make reference to hypertension being the blood pressures being measured at 2 hours or 4 hours apart. But in the recent national guidelines published, it now reduces it to 15 minutes apart. Okay. The International Society for the Study of Hypertension in Pregnancy classifies it into 5 main categories. So here we have chronic hypertension, which is defined as hypertension predating pregnancy or diagnosed before 20 weeks of gestational age. White coat hypertension, which is elevated office blood pressure levels above or equal 140/90, but normal when the patient is at home. This condition is not benign, and women suffering from white coat hypertension have about a 25% chance of developing gestational hypertension and pre-eclampsia later on in pregnancy. Gestational hypertension is defined as a new onset hypertension after the 20th week of pregnancy. And pre-eclampsia is not now defined only by proteinuria, but also if there is plus or minus evidence of organ dysfunction occurring after the 20th week of pregnancy. We'll look at this just now. And then there's the last category, which is the HELP syndrome. This is characterized by hemolysis, elevated liver enzymes, and low platelet counts. So let's take a closer look at pre-eclampsia. Pre-eclampsia is gestational hypertension accompanied by more than one of the following new onset conditions after 20 weeks gestation. So you have proteinuria or any evidence of maternal organ dysfunction. And this can be acute kidney injury determined by a creatinine level of 90 or more. Please note the unit as micromole per liter. Different laboratories may be using different units. Liver involvement marked by an AST or ALT, sorry, this is ALT, of more than 40 international units per liter, with or without right upper quadrant pain or epigastric pain. Any neurological complications, such as seizures, altered mental status, blindness, stroke, clonus, severe headache, or persistent visual scotomas or any visual disturbance, hematological dysfunction of platelets less than 150,000, DIC, or hemolysis. And lastly, looking at the fetus and placenta, any evidence of fetal growth restriction, abnormal uterine artery Doppler waves, or stillbirth. Any of these conditions, if present with or without proteinuria, defines pre-eclampsia in the mother. Now, we are going to take a few steps to look at what the guidelines are actually saying. So in terms of measuring blood pressure levels, the guidelines advocate that we should use validated blood pressure machines for pregnant women. So there was a study done, and it advises that we use a blood pressure machine called a Cradle Alert, which actually has a traffic light system in it with different colors, which alerts the clinician that there's a problem of hemorrhage or sepsis or elevated blood pressure in pregnancy. That is the ideal blood pressure machine to use in pregnancy. However, this is currently not very much available in the country. South Africa is still advocating for these machines to be made more available to us. So in the meantime, the blood pressure machine should be often validated. The blood pressure should be taken with the patient in the sitting position, legs uncrossed, relaxed, arms should be free of clothing, and the arm should be supported at the level of the heart. Repeat the blood pressure reading after 15 minutes if you detect that it is higher than 140/90. And find the average. The level of blood pressure agreed as hypertension, as I already mentioned, was 140/90, equal or above. In patients who are noted to be obese, with a mid-upper arm circumference of above 33 or a BMI above 33, the blood pressure should be taken with a larger blood pressure cuff. Okay. Patients seen at our clinics and hospitals who present with a systolic blood pressure between 130 and 135 and 139, or a diastolic blood pressure between 85 and 89, should be made to rest, and the blood pressure should be retaken between 30 minutes to 2 hours. And if the blood pressure is still within these levels, the patient should be asked to come back within a week for a repeat blood pressure check. This condition is previously known as pre-hypertension. It's now called borderline hypertension. They are not hypertensive, but they are at a higher risk of developing gestational hypertension in that pregnancy. And currently, the WHO recommends calcium amounts of 1.5 grams for all pregnant women. Calcium has been proven to reduce the risk of getting hypertension in pregnancy. In the South African trials, it was found that as low as 500 milligrams of elemental calcium daily was almost at par as the 1.5 gram recommended by the WHO. So currently, South Africa our guidelines recommends giving all pregnant women at any level of gestation 500 milligrams of elemental calcium during the pregnancy. It's easier to swallow, cost-effective, and has a lesser risk or side effects. The calcium and iron that we give these pregnant women should be given at an interval of 2 hours. Okay. Concerning aspirin, aspirin has been found in there. So was a study conducted called the aspirin study, which showed that a low dose aspirin of about 75 to 150 milligrams taken at night prevents pre-eclampsia up to the risk of pre-eclampsia up to 80%. So the national guidelines recommends that we use aspirin. We give aspirin to women identified with risk factors for pre-eclampsia. The aspirin should be given as early as possible between 12 to 14 weeks, or can be given up to 20 weeks. But it has been shown that women who have it earlier than 20 weeks have more benefits from aspirin use in pregnancy. Women who are found to have proteinuria, using the visual dipsticks or automated dipsticks, should also be a blood sample, a urine sample should be taken to determine the protein creatinine ratio. The 24-hour urine protein creatinine ratio is actually the gold standard, but for convenience purposes, we can also do a spot protein creatinine ratio. Values are between 0.3 milligram per milligram or above are said to be abnormal. So we want values around less than 300 milligram or less than 0.3 grams. During the history taking, we noticed that most of our clinics use general nurses to take history from the patients. And these nurses are not very much experienced in hypertension disorders in pregnancy. So the general nurses should be given a checklist of which questions to ask these patients and cross-check this list, and then look out for the risk factors identified in this in section 8 here. And if any of these risk factors are present, put these women on aspirin therapy. So here, you look at it, these are major risk factors for pre-eclampsia in a pregnant woman. There are other risk factors, which are the minor risk factors, but we're going to concentrate more on the major risk factors, which are a previous history of pre-eclampsia in an earlier pregnancy, and mother with chronic hypertension, patients with multiple pregnancy, patients with pre-gestational diabetes, maternal BMI above 35, patients with a history of antiphospholipid syndrome or SLE, and patients who got pregnant through assisted reproductive methods. All these patients should be on aspirin therapy. Also, the guidelines advocate that women at high risk of pre-eclampsia or women with pre-eclampsia should be referred to the next level of care. Here, the next level of care referral does not necessarily mean a tertiary hospital or regional hospital, district hospital. The next level of care can be an advanced midwife, a family physician, if available in that facility, an experienced doctor who takes care of pregnant women, and that facility must have access to rapid results for hemoglobin, platelets, urea, creatinine, and ALT and a sonar machine. In defining the protocols for our facilities, the apex hospital, maybe the regional hospital or tertiary hospital, should be involved in defining the protocols so that we know, clinicians know what facilities can manage what and which patients should be sent out. So for instance, if you are running a clinic and there's a family physician in that CHC or that clinic, a nurse or midwife can refer a patient suspected with hypertensive disorders of pregnancy to the family physician on that day or within a few days, and that will be the next level of care referral. Okay, now let's have a closer look at the algorithm for hypertension in pregnancy for primary health care. So at the primary health care level, we are looking at mobile clinics, we are looking at CHCs, we are looking at 8 to 4 p.m. clinics. Okay, this excludes the district hospital. So if a woman comes with a systolic blood pressure between 135 and 139, or a diastolic blood pressure between 85 and 89, you are advised to repeat the blood pressure after the patient has rested within 2 hours. If the new blood pressure is still found to be still above 135 but below 140 for systolic, or between 85 and 89, the patient should be asked to go home and come back within 1 week for a review or a repeat blood pressure assessment. This patient has borderline hypertension, or what we call pre-hypertension. She is not hypertensive, but can develop hypertension in that pregnancy. So you review this patient according to what blood pressure levels you get. And so the blood pressure is at a level below 135, where she resumes her normal antenatal care plan. If the blood pressure is above or equal to 140, the next step is to assess this woman for risk factors. We already mentioned all the risk factors, is still written up here. So if there are presence of risk factors, so if the patient has any of these risk factors, pre-eclampsia history, chronic hypertension and going on, assess the woman for proteinuria using automated urine dipstick devices, or in the absence of that, use a visual dipstick. If there is proteinuria, the diagnosis of this woman is now hypertension with proteinuria 1+ or more and no severe features. So now you have to assess the woman whether she has severe features. Severe features here being defined as the presence of headache, visual disturbance, chest pain, epigastric pain or epigastric discomfort, or seizures. Now we'll continue this algorithm. Now, if you assess the patient and the patient has no risk factors, has risk factors but no proteinuria, the diagnosis of this woman is now hypertensive disorder of pregnancy.
I think it's if a person passes 5 out of 10, or fails in 5 out of 10, that could be accounted for that he just had one bad station. But 7 speaks of a consistently poor performance clinically. 6 and 7.
Hello, Prof. Your mute is on, your speaker is on. Okay, let's continue. I think that was beside the presentation. All right, so in continuing to assess these women, if you have a patient with hypertension in pregnancy, assess for risk factors. If there are no risk factors, assess for proteinuria. If there is no proteinuria, this patient has gestational hypertension, and this patient has gestational hypertension, which is hypertension with no risk factors, no proteinuria, and no symptoms. The patient should be started on alpha-metaldopa, 500 milligram 8 hourly, and then refer to the next level of expertise within 3 days. We already defined what the next level of expertise here is. Do blast before referral, and if the sonar is available, assess the fetus for how the fetus is growing, the amniotic fluid volume, presence of a fetal heart, and so on and so forth. If you have a patient with hypertension and no risk factors and the presence of proteinuria, this patient has pre-eclampsia, but no severe features. In terms of severe features, we are looking at blood pressure above 160/110 or the presence of headache, chest pain, epigastric pain, or discomfort, or seizures. So here, if the patient has pre-eclampsia but no severe features, start metidopa, take bloods to investigate pre-eclampsia, and refer the patient on the same day to the district hospital if you're at a clinic or a mobile clinic or a CHC. All right. Now, still looking at this algorithm, if the patient has risk factors, you're going to start the patient on aspirin, and you're going to start the patient on aspirin, assess for proteinuria. If there is no proteinuria, start her on metidopa and refer her to the next level of expertise within 3 days. So as we go on, we'll keep coming back to the algorithm and allocate and see how it is applied in the clinical scenarios. Now, if you have a patient with pre-eclampsia with severe features or blood pressure above 160/110, this patient needs to be stabilized. So here you can see that severe features is written here: headache, chest pain, epigastric pain, discomfort, visual disturbances, or blood pressure above 160/110. Stabilize the woman. And by stabilizing this woman, what we mean is you're going to have to start the patient on magnesium sulfate protocol. So here, this is what we mean by stabilize the woman. So this is actually an acute obstetric emergency, pre-eclampsia with severe features. Blood pressure of above or equal to 160/110, the presence of headache, epigastric pain, epigastric discomfort or chest pain, and visual disturbances. Start an IV line in one arm with 200 ml Ringer's lactate. Let it run slowly at 80 ml per hour. It has been found that one of the causes of accelerated complications in these patients is actually fluid overload. In this, even though they may have some volume depletion and capillary leak, you don't need to overload them as their heart is already strained. So you give them very little fluids, and then you start them on the magnesium sulfate protocol of 4 gram IV and 10 milligram IMI, 5 gram in each bottle. After you successfully loaded them with magnesium sulfate, you now reduce the blood pressure with quick-acting nifedipine orally. The quick-acting nifedipine here is different from the sublingual one. We know that you put a needle in and then you put under the tongue. This is a tablet you put under the tongue of the woman if she cannot swallow. If the woman can swallow, she takes it with water and swallows the tablet. You can keep repeating the nifedipine 10 milligram every 30 minutes until the blood pressure drops below 160/110. At the same time, you give her 1 gram of alpha metidopa orally. And then when the woman is stable, you assess the fetus. So you do a sonar to assess if the fetus is still alive. This is not the time to monitor the fetus. Only monitor the fetus when the woman is stable and you have decided that you're going to deliver this baby safely in a district hospital. Insert a urinary catheter, monitor the urine output every hour until the woman is transferred. And during the transfer, the woman must be accompanied by an experienced nurse or a midwife, as our current emergency service personnel are not allowed to give magnesium sulfate in the ambulance. They are not allowed to do vaginal examinations or abort seizures. So it's better if it's accompanied by an experienced midwife or nurse who can give those medications should it be necessary in the transport. Use the SBAR form. The SBAR form is a situation, background, assessment, and recommendation form. Fill it out and transfer the woman in the lateral position. All women with signs of pre-eclampsia or gestational hypertension have to have a full history and systemic examination done. All right, moving on. So after listening to all that, let's look at this case and use this to revise our algorithm. So here we have a 21-year-old gravida 1 para0 female with no medical comorbidities presenting to the antenatal care clinic for her first time. Her blood pressure at the visit was 110/60, and the urine dipstick was normal. Her SFH was 20, which was consistent with her dates. All other investigations are found to be normal. At this point, what is the next appropriate step? Can anyone answer?
If you can lift your hand, I'll unmute you. Just raise your hand. I think Dr. Shabir is willing. Go ahead, Dr. Shabir.
I think you should start calcium, because you mentioned that in the guideline it says that you can start calcium for all the pregnant women at any gestational age. And then iron actually is what we are giving even from the beginning of the pregnancy. So I think that that's the best answer. I don't know what you will say.
That's correct, Dr. Shibeya. So you give this patient calcium and iron, and remember to give them at 2 hours apart. The interval between calcium and iron should be at least 2 hours apart. Okay, thank you very much. Moving on. So let's look at this one. A 30-year-old Gravida 1 para 0 comes for her first visit to the primary care. She's HIV negative. Her blood pressure is 135/86. Her SFH is 29, which is consistent with her dates, and the heart rate is 88. Respiratory rate is 14. She has no symptoms. Urine dipstick is normal. What will we do next?
Please feel free to raise your hand. Nabila, Nomfundo. Okay, Roland.
Thanks, Roland.
I think that you should repeat blood pressure in 2 hours. Huh? I don't know.
Thank you. Yes, so this patient has borderline hypertension. Her systolic is 135, diastolic is 86. And so you repeat the blood pressure in 2 hours. If the blood pressure is still within 135 to 140 or 85 to 90, this patient, on the repeats, the patient will be asked to come back in 1 week for review. So that was it. The answer is repeat blood pressure in 2 hours. The repeat blood pressure was 136/86. Oh, I already answered this question. Okay. So I already answered that question. So that was a repeat blood pressure. The patient was asked to come back within the week. So on our algorithm, we already saw this. Now let's continue the scenario. As the patient comes back and the blood pressure had gone low, she was followed up with a normal antenatal care intervals until 33 weeks, when she came back with a blood pressure of 150/91. She had no symptoms and no proteinuria. What is the next step? If you could remember the algorithm, we went very fast. We don't have a lot of time, so if you know it, just raise your hand and we'll speak. Thanks, Roland.
Yeah, I think you start her on alpha methyl dopa and refer immediately.
All right, so the patient now has gestational hypertension. So let's see what the answer says. We look at the algorithm again. So this patient has a blood pressure of 150/91. She's asymptomatic. She has no proteinuria. This is the algorithm for a CHC, a clinic or mobile clinic. You are not at the district hospital. You cannot keep this patient with gestational hypertension at the clinic. So the correct answer here, according to the algorithm, will be, there's no proteinuria, we go here, is start alpha methyl dopa and refer to the next level of care within 3 days. So here the answer is C. All right, and then if the sauna is available, you can do the sauna. Because we are referring within 3 days, you still have enough time to do your investigations. So you can take bloods for hemoglobin, platelets, creatinine, and liver enzymes. Or if there's a sauna available, you assess the fetus once the mother is stable. And then you take urine for MCNS, PCR, or 24-hour if the patient had proteinuria. Okay. So refer to the next level. Okay. Case 3. A woman comes to the primary health care complaining of epigastric pain and pedal edema. She's obviously pregnant. This is her first visit. During the history taking, you see that the patient has had a convulsion. After preventing her from falling, what is the next step to do? Okay, because of time, I'll just move on. So in this particular scenario, this woman has eclampsia. And eclampsia is an acute obstetric emergency. When you have patients with an acute obstetric emergency, what you do is what we call the ESMO steps. which is the shake and shout, call a cab, and reassess the patient. So here, the correct answer will be to place her in the recovery position. So the immediate actions you do with a patient having a generalized convulsion will be you call for help, protect the airway and place the patient in the recovery position, extend the neck of the patient, suction the airway if there are secretions, and insert an oropharyngeal airway if possible, and then start oxygen by face masks. Then you call a cab. So here we have call a cab, as you can see here, which is circulation, airway, and breathing. So you assess her circulation by taking her blood pressure and pulse. You assess the airway to see whether it's open, and then you assess the breathing by listening to her lungs and doing a pulse oximetry for oxygen saturation. You're checking the patient for pulmonary edema. The next step, after you've called for help, assess neurological function and level of consciousness, protected the airway and all that, the next step is to do what we call the big five, forgotten four, and core one, which are all in the ESMO guidelines. So the big five here, we're talking about doing the full history and examination for this patient. So assess the central nervous system by asking questions, assess the level of consciousness, test the patient's reflexes, ask about new onset headaches, which have not been resolving, and visual disturbances. Assess the blood pressure, the cardiovascular system by taking the blood pressure and measuring the apex, where the apex beat is, and listening for the heart sounds. The gastrointestinal system, palpate the liver for epigastric pain or right upper quadrant tenderness, take bloods for ALT and AST levels. The respiratory system, listen for the lungs and measure the respiratory rate. Assess the renal system by measuring the urine output, check for proteinuria, and if creatinine is above or equal to 90, that's pre-eclampsia. So you also measure the patient's creatinine. The forgotten four is the immune system, hematological system, endocrine system, and musculoskeletal system. So the immune system is take the everyone's temperature and ask about HIV status. Hematological system, measure the HB and platelets. Endocrine system, examine the breast, the thyroid, and blood glucose levels. The musculoskeletal system, assess for pedal edema and ecchymosis on the limbs. The core one refers to the uterus and the fetus, and also the genital system to assess whether she's in labor or not. So you assess for contractions, the lie and presentation of the baby. If you have a sonar, you do the fetal weight, fetal heartbeat, whether the baby is alive, and amniotic fluid volume and placental placement in this patient. So these are the ESMO steps for acute obstetric emergencies. They apply for all obstetric emergencies. All right, moving on. So now you've done your immediate actions, you've assessed circulation and blood pressure and everything, and you find that the blood pressure is 190/105, the pulse is 418, the respiratory rate is 26. What is the next thing to do? Hi, Roland, can you tell me? I saw your hand up. Oh, you put it down.
Okay. Oh, sorry. Can you hear me now?
Yes.
Yes, I think that the answer is B. You should load with IV and iron, magnesium sulfate.
Excellent. So exactly, that is the exact answer you should do with this patient. So that when we looked back at how to stabilize the patient, we looked at, let me go back a few slides again and we recap because I went through it really fast. So here, the first thing you have to do after you've done your ESMO steps is to put up an IV line with 200 mils Ringer's lactate, run it slowly at 80 mils per liter per hour, and then start magnesium sulfate protocol. Give the loading dose and continue with the IMI injections. So that's what we just said. And so you've given her IV and magnesium sulfate. Now, the patient is now post-ictal because she came in and then she fitted when you're taking your history. You've done your assessment. The blood pressure is now 165/110. Heart rate is 111. Respiratory rate is 24. The lungs are clear. You don't have a SAS monitor. You remember you were at the clinic and you were seeing patients in the consulting room. The dipstick on her sheet tells you she's got 3+ proteinuria with scanty, and it was scanty urine. The glucose is 6 millimole per liter. SFH is 35. Fetal lie and is longitudinal and cephalic, and presentation is cephalic. Now, this patient is not in labor. What is the next step to do? Thanks, Roland. Hello, I thought I saw your hand.
Oh, sorry. Sorry, I forgot to unmute. Sorry, I think it's oral nifedipine. Until the blood pressure becomes lower than 160 over 110, lower than that.
Thank you, I appreciate. So you give that, you've already started your magnesium sulfate protocol. The next step in stabilizing the woman is to start oral nifedipine. Now here, I want to mention that depending on where you are, we are looking at the algorithm for clinics and CHCs and mobile clinics here. So they do not have labetalol. But if you were in a hospital or facility that has labetalol, you could give labetalol. But currently, with the facilities that we have at primary healthcare, we don't have access to labetalol or the monitoring that comes with it. So you give oral nifedipine 10 milligram, the patient swallows it, and then you can repeat the nifedipine every 30 minutes until the blood pressure goes below 160 over 110. All right, so that was the answer. Now let's look at the algorithm for the district hospital with cesarean section capabilities. We already went through borderline hypertension earlier. Is the same at the district hospital. So we are going to concentrate on patients with hypertension. And by hypertension, I mean blood pressure at or above 140 over 90. So let's look at if the patient comes and has hypertension, but no proteinuria. You start this patient on 500. Now you are at the district hospital. You start this patient at 500 milligram alpha metaldopa 8 hourly and follow her up within a week to see if the blood pressure is controlled. This patient has gestational hypertension. So you follow up every week until you plan delivery for this patient. Hopefully, if she doesn't develop any signs of pre-eclampsia throughout these follow-ups, aim for delivery at 38 weeks or before 40 weeks gestation. During this period, you take blood for, do your blood investigations, which we mentioned earlier, and assess the fetus with an ultrasound. If the patient has features suggestive of pre-eclampsia, now if a patient with pre-eclampsia, you're going to have to confirm the diagnosis. By confirming, I mean take a full history of this patient, do a full examination of all the 10 systems I went through earlier, including the fetus, do your blast, do your sauna, take urine for protein to quantify your proteinuria in 24 hours and plan delivery as soon as possible. If the pregnancy is less than 34 weeks, between 28 weeks and 34 weeks, this patient is going to need steroids and plan delivery after 48 hours of steroids administration. If you're in a district hospital with cesarean section capability, and at this level, you need to have an experienced obstetrician or an experienced specialist, be a family physician, or and an experienced anesthetist or a specialist anesthetist to manage the patient, which can complicate at any time. We no more classify pre-eclampsia as mild, moderate, severe. It's now pre-eclampsia with or without severe features. So these patients can complicate at any time and often quite rapidly. And so they have to be monitored very, very carefully. Ideally, all patients with features suggestive of pre-eclampsia should be managed at a regional hospital or a tertiary hospital and not at a district hospital. However, because of resources, what the guidelines advocate that the apex hospital within that catchment area should define which patients should be seen at the district hospital and which patients should be referred to the regional hospital according to the local protocols. If the woman has pre-eclampsia with severe features, you have to stabilize this woman according to the protocol, the magnesium sulfate protocol we went through. Give steroids if the gestational age is less than 34 weeks to stimulate fetal lung maturity. Assess if the patient is in labor or not. Now, if the patient is in labor or within imminent delivery, stabilize the patient and deliver the baby at the district hospital and then refer the patient to a higher level of care. If the patient is not in labor, transfer the patient immediately to a higher level of care if the gestational age is less than 34 weeks. If the gestational age is 34 weeks or above 34 weeks, you need to consider whether this patient can be managed at the district hospital level or not. The decision to deliver this patient at the district hospital should be taken together with the obstetrician at the higher level of care for them to know that there's a patient at the facility with this condition and advise deliver the next steps to take. All right. Okay. So if the pregnancy is less than 28 weeks with pre-eclampsia, but no severe features or gestational age between 28 to 33 weeks, I already went through this. Stabilize the woman, take your history, take your clinical examination, confer with the doctors at the next level of care, whether you should give steroids or magnesium sulfate at this stage, even though there is no severe features. And if they advise that steroids should be given or magnesium sulfate should be given, give it and refer the patient to the, transfer the patient to the higher level of care. This patient should not be kept at a district hospital. Should they develop complications and the baby needs to be developed to be delivered, these patients are at very high risk of severe or extreme prematurity. At gestational age of 34 weeks or more, pre-eclampsia with no severe features, it is strongly recommended that these patients should be delivered. Their pregnancy should be terminated once pre-eclampsia develops. However, this decision should be communicated to the patient. The patient should be made fully aware of the risks of delivering their baby at that stage, and the decision should be documented and informed consent should be signed. The patient can have her family, husband or family members together make this decision, and all information here should be very well documented. The risks versus benefits should be explained to the patient that in terms of saving her life and also the risk of prematurity in these babies. Because although the pregnancy is more than 34 weeks, these babies are still at high risk of prematurity complications. For patients with gestational hypertension, we already went through this. They should be seen weekly at the antenatal clinic and delivered before 40 weeks at the district hospital. On no account should a woman with features of pre-eclampsia be sent home and reviewed as an outpatient. These women should be treated as inpatients because their condition can change quite rapidly. Okay, so at the district hospital level, we have a 21-year-old gravida one. This was our first patient we saw earlier on. She was referred to the next level of expertise within 3 days, and now you are the family physician she's come to see. She had been followed up at the clinic until she was 33 weeks when she was started on alpha metaldopa 500 milligram TDS. Her blood pressure was well controlled on alpha metaldopa until she was 34 weeks when she developed pre-eclampsia, 150/105 blood pressure and proteinuria of 1+. Her HB was 13, platelets was 225, creatinine was 65, ALT was normal. The sonar showed a normal fetus at 36 weeks with an estimated fetal weight of 2.8 kilograms. So now she's been referred, she's come to you. She's now 36 weeks, actually. Okay. What is the most appropriate next step? Are we going to induce labor? Are we referring to a regional hospital? Are you going to repeat the full history, examination, and blood tests, or you are going to give steroids? Who wants to try this one? We have only about 15 minutes, so. Thanks, Roland. Can you unmute? Yes, Roland. We can't hear you. Yes.
Can you hear me? Yeah.
Yes.
I think this stage, the answer should be we should refer to a regional hospital.
Okay, so thank you. So the correct answer here is to repeat a full history, do your own clinical examination, blood test, and so on. As I said earlier, this patient has now presented with pre-eclampsia. So as part of your stabilization protocol for this patient, you need to assess all the 10 regions, which is your big 5, forgotten 4, and core 1. So you need to take a full history for this patient, do a clinical examination for a central nervous system, her gastrointestinal system, respiratory system, renal system, hematological system, endocrine system, musculoskeletal system, and the immune system, and then assess the fetus by ultrasound as well. Because once she's developed proteinuria, she may be having other complications going on in the other system. So you want to have your full information, and the blood tests will now guide you as to what to do. If you were in the clinic or CHC, you just refer on the same day to a district hospital. But now you are in a district hospital, you are the specialist there. And ideally, they should be referred seen in a regional hospital, but you are in a facility with capabilities to do these blood investigations. So you can do them before you transfer this patient to a higher level of care. Okay. So, so now we have a patient. So this patient that we saw earlier on is hypertensive with features of pre-eclampsia defined by the proteinuria 1+ that we saw. All her other lab investigations were normal. So just to revise the algorithm quickly. So the blood pressure was elevated above 140/90. She had features of pre-eclampsia. She had hypertension and proteinuria. You confirm the diagnosis. So the confirming the diagnosis is the history, the full clinical examination of the fetus and doing your bloods. Establish the correct gestational age. So the donor said it was 36 weeks appropriate to the gestation. And then you do your urine MCS and protein creatinine ratio to establish whether there is a true proteinuria or a proteinuria due to infective causes or other causes. And then you consider delivery. If the patient is in labor, or if she's not in labor, you transfer her to a higher level of care, depending on the diagnosis and context from your investigations and history. Now you've done your full history and examination on this patient. You find that she's awake and alert. She has no symptoms. The blood pressure is 150/100. The pulse is 85, respiratory rate is 80, and she's got epigastric tenderness with ALT around 100. When you repeated your bloods, your urine protein is 0.6 gram in 24 hours. Creatinine is 102. She's passing urine over 40 mils per hour. Her HB is 13, platelets is 105, HIV is negative, temperature is 36.8. And glucose is 5.3. She's got pedal edema up to her thighs. Her SFH is 35, fetal heart rate is 150, and the lie is longitudinal cephalic presentation with adequate lico. She is not in labor. So these were your findings on taking your history and examination and doing your bloods. What is the most likely diagnosis for this patient? Can someone other than Roland try? I see we have about 38 participants.
Let's see.
Hello?
Anyone else?
Yes.
You can always call someone out if you want.
Let's see. Roland, I'll call you when I don't get someone. Should I call out?
Yeah, use that. Do that.
We only have a few
minutes. You have to push participation
on time. Yeah. Okay, Roland, try. I think our participants are listening. Yes, Roland, go for it.
Yes, I think it's pre-eclampsia with HELP syndrome.
Yes, so correct. This patient has pre-eclampsia with HELP syndrome. Let's look again at our bloods. I'm trying to go back. Okay, so you notice here she's got epigastric tenderness. She's got ALT at 100. So we defined pre-eclampsia as we want ALT not to be above 40. There is some literature that says above 70 or 2 times the normal limit. But the national guidelines and the Brown et al. Article for international practice advocates ALT levels at less than 40 international units. This patient has ALT above 100 and also platelet levels at 105. Normal platelet levels should be between 150 and 450. So with these two things going on, although her HB is normal at 13, this patient has pre-eclampsia with HELLP syndrome. She has severe features and she's very sick. Okay. So moving on. So what will be the next step now that we've correctly diagnosed these patients as pre-eclampsia with HELLP syndrome at the district hospital level? Okay, I'll just answer the question. So the correct answer here will be to refer to a regional or tertiary hospital, whichever is closest, because this patient is very sick and needs close-up monitoring, probably in a high care facility or an ICU if available. There's very high risk of maternal complications or fetal complications with this syndrome and risk of death. So quickly revising pre-eclampsia with severe features. So we define severe features as headache, chest pain, epigastric pain, or discomfort or visual disturbances. Our patient has epigastric pain. That alone tells us it's pre-eclampsia with severe features. Then we have to stabilize this woman, put up an IV line, start magnesium sulfate protocol, give her nifedipine, assess the gestational age. If less than 34 weeks, give steroids, and then assess if the patient is in labor or not. If she's in labor, you allow and there's imminent delivery. So with labor, you want to see whether this patient is going to deliver before she arrives at the tertiary or regional hospital. So if the regional hospital is far away and it's going to take her hours to get there, you may as well keep her at the district hospital, stabilize and deliver the baby, and then refer. But however, if she is in the early latent stages of labor and the regional or tertiary hospital is within 30 minutes of reach, and the patient can arrive there before she delivers, you stabilize and then you transfer the patient to the higher level of care. So it depends on whichever one is closest to you and the status of her Bishop's score, cervix, dilatation, presentation, and station of the fetus. Okay. So whichever one is closest. Now, moving on, a 36-year-old patient who is 34 weeks pregnant presents to the ED with a blood pressure of 165/100. The heart rate is 130 beats. The respiratory rate is elevated at 45 breaths per minute. She's having difficulty speaking. She has widespread crepitations and wheezing and oxygen saturation at 85%. You've given her oxygen, and you've done your call a cab and all your SBO principles. What is the most appropriate next step to do in this patient? Who wants to try? Okay, I'll just answer. So the correct step to do here is to give the patient, go through your ESMO steps. So here, we have this patient presenting with severe features, most likely pulmonary edema, with a blood pressure of 165/100 and pregnant. That will probably be your first, that should be your first differential, although there are other conditions that can present like that. So go through your ESMO steps and call for help, assess the neurological function, look at this, measure the blood pressure and pulse, assess the airway and breathing, examine all your 10 systems, and then protect the airway and place in a fowler's position. And then, so that is your first step to do, and then give her IVI furosemide. So you've done all that. Oh, I think I repeated the question here. So the next step is to give IVI furosemide urgently. Then you stabilize the patient going through the max sulfate protocol. Okay. So patient scenario continued. So that on further history, when you did your history and examination, she's a gravid at 3/2. She's got shortness of breath. That started early that morning, got worse. Chest feels heavy. She has hypertension diagnosed a year ago, which has always been well controlled until now. And she's already on calcium and aspirin since she started antenatal care at 12 weeks. When you examined the patient, you found out her apex beat was deviated in a safe intercostal space. Her respiratory rate was, this is supposed to be 18 here, not 8. The saturation is 95. Her oxygen is 40%. And after you gave the IV furosemide, she has 1 plus of protein and her HB is 10. She's not in labor and the fetus is normal and doing well with a cephalic lie. All your blood results came back normal. What is the next thing to do? This is a patient with pre-eclampsia and pulmonary edema, and you are at the district hospital level.
Any hands?
Yes, Roland? Hello? Roland, we can't hear you. I think you are muted again. Okay, well, I'll just answer. The correct answer here will be to refer her to a higher level of care. This is a patient presenting with pre-eclampsia with severe features. So again, look at the blood pressure on arrival was 165 over, I think 105. And she is already showing respiratory system in complications with pulmonary edema. So here you have to refer the patient urgently to a higher level of care after you've stabilized the patient. Okay, and the pregnancy was at 36 weeks, I think. Let's see, go back. I don't have it here, but we did a sonar, I think. Yes, her SFH was around 32. All right, okay. So if the pregnancy was around after 34 weeks, you don't give steroids. But if since the pregnancy is around 32 weeks, you still have to give steroids and then you refer the patients. All right, but the correct answer here is to refer to higher level of care. Okay. Now, thinking other differentials that can occur with a patient like that could be a pulmonary embolism, which you need to investigate for. The patient could be having an MI. It could be a cardiomyopathy. It could even be an infective cause like pneumonia or TB. These are all differentials you should consider in patients who present with shortness of breath and in pregnancy at advanced gestational age. Thank you very much. I think I made it.
Yeah, absolutely. Thank you. You've been spot on time. Thank you. No, thank you very much. I think I really appreciated it. And I think especially the fact that you're interacting, it's just challenging to get people participating, but we look at trying to work with other tools to make it more interactive. If you don't mind, before we stop, that you just fill this in so that we can have a sense of who's joined us. I think of the 30 odd people that are here, I think it'd be very useful for Dr. Alagadede to have that as a sense of who's been benefiting from her time and energy spent before you disappear. So, Anne, thank you. This was really great. And I think that, you dealt with it, I think, as a family physician would from primary care and provided useful insights. And I think referencing important guidelines and important recent guidelines. I'm sure the interns are much more familiar with it, but I think thank you for sharing that. So thank you all. I think we almost got as many as we can. So I think you've got some, yeah. Do you mind sharing with me the references? And I think there's a question from, is it Yvonne Malloy about the algorithms for CHCs? Are they available?
Yes, all the algorithms for CHCs are available. I shared the article that you can find them in. Let's go back to the reference.
No, that's fine. You can send me that, and then I'll put it up on the website with the reference with your slides, so at least people can do that. So let me just share quickly who's been with us. I think it's family medicine medical officer, mostly interns, Southern Africa, although I see people from Tanzania, and Kenya that have joined us somewhere in between. So let's stop there. So let me just share this quickly and say to you, thank you. You'll send me those guidelines and
Yes.
any protocols that are relevant to the district and for use to other people. So thank you. And I hope that other registrars will also be stepping up and doing like you, Anne. I know it was tense for you, but thank you. You did a wonderful job. And I did think really went about it well. So thank you all very much. Thank you, Anne. And thank you all of you.
Sorry, I rushed so much. It's a lot and it's just 1 hour. So yeah.
I know. You did spot on by keeping it trim. And I think, yeah, you went about it in a good way. Thank you. I'm sure everybody appreciates that. So let's stop there. Thank you very much, everyone. Enjoy yourself for the next week. See you next week. Bye-bye. Anne.
Bye-bye.
Bye-bye, everyone.